Hello and welcome to this AC Forum webinar. We have quite a number of registrants. Over 1,300 people have registered for this webinar today. So I'm going to give a minute for everyone to join into the room and we'll get started. Well, welcome everyone. Good afternoon, good morning, depending on where you're at. I'd like to welcome you to this webinar on direct oral anticoagulants versus vitamin K antagonists in thrombotic antiphospholipid syndrome, looking at a meta-analysis of randomized controlled trials. Go to the next slide, please. I am Geoff Barnes. I am a cardiologist and vascular medicine specialist at the University of Michigan. I'm also an AC Forum board member and member of our webinar team. And along with my good friend, Dr. Deborah Siegal, who's an associate professor in the Division of Hematology at the University of Ottawa, we are thrilled to welcome three wonderful presenters and panelists today. You can see them here. We have Dr. Behnood Bikdeli, who is a cardiologist and vascular medicine specialist at Brigham and Women's Hospital. He's also associated with the Yale Center for Outcomes Research and Evaluation. We also have Dr. Jean Connors, who's the medical director of the Anticoagulation Management Service and a hematologist at Brigham and Women's Hospital and the Dana-Farber Cancer Institute. And then lastly, we have Dr. Surabhi Palkimas, who is a pharmacist and pharmacy administrator at the University of Colorado Hospital. And we're going to be learning from all three of them today. Thank you all for joining us. Our next slide will show our disclosures. And you can see some of these disclosures relate to companies that either make anticoagulants or are involved in anticoagulation care. But I'm going to go ahead and get us started here. As we always do, I'm encouraging you to put your questions into the Q&A at the bottom and let us know if you have questions. We'll address all of those at the end. But let's turn things over now to Behnood, who's going to walk us through the meta-analysis that he performed.
Thank you very so much, Geoff. And I appreciate and express my deep gratitude to Anticoagulation Forum and the panel of experts for this opportunity. Here are my disclosures, most of which are not relevant for this talk. So to begin with, we know that antiphospholipid syndrome is a systemic autoimmune disorder, and we call thrombotic APS when there is micro or macro thrombosis associated with the classic pattern of abnormal antibodies that are seen in this condition. And the results obviously have to be confirmed at the very least in two separate occasions, 12 weeks apart, so that we can make the diagnosis. And a lot has been advanced in terms of our knowledge of pathophysiology of this condition. Suffice it to say that before COVID, it gave us some good clues about how thrombosis and inflammation can interact together, and the interplay involves multiple things, including but not limited to neutrophil endocellular traps, extracellular traps, and increase in tissue factors, several other pathways, reduction in fibrinolytics, et cetera, that ultimately culminate into excessive risk of thrombotic events in these patients. And Anticoagulation Forum has put together this beautiful summary document that Surabhi will be alluding to in a little while. And here I want to quickly touch upon direct oral anticoagulants for people with thrombotic APS. Obviously, as most other scenarios, they're a lot more convenient and there are less challenges for monitoring and titration, even maybe more so in APS, for whose patients there are at times difficulties with titrating VKAs, et cetera. However, the efficacy and safety of DOACs versus vitamin K antagonists have been really not well characterized. And part of it is because of some individual randomized trials that reported interesting results, but not sufficiently conclusive to understand what's happening. RAPS was one of the first studies, which was a short-term randomized trial of rivaroxaban versus vitamin K antagonists with a target INR of 2.223. And these patients received 3 months of treatment, and a little over 50 were assigned to vitamin K antagonists and a comparable number to rivaroxaban. And ultimately, the primary outcome, which had to do with endogenous thrombin potential, was not significantly different. There was a difference, but it wasn't to the extent that made a clinical difference because no thrombotic events were actually reported in these patients. TRAPS was a longer follow-up randomized trial, again comparing the same dose of rivaroxaban, 20 milligrams once daily, compared with vitamin K antagonists. And here, the trial was prematurely terminated, in part because there was a concern for harm with extra numeric events for ischemic stroke, 3 additional myocardial infarctions, all associated with the rivaroxaban arm and none seen in the vitamin K antagonist group. And there were numeric differences in terms of bleeding events and major bleeds, even though they did not reach statistical significance. The authors reported a composite primary outcome that included thromboembolic events, major bleeding, and vascular death that was also showing an increase in the hazard with rivaroxaban compared with vitamin K antagonists. So this study gave some clinicians and investigators a pause. And this was followed by another randomized trial, this time around 190 patients, again with thrombotic APS, randomized to VKAs versus rivaroxaban. And to make a long story short, because I want to get to the meta-analysis, again, directionally, the results were showing excess in arterial thrombotic events, not VTE, in patients who received rivaroxaban compared with vitamin K antagonists. And this randomized trial was designed to show non-inferiority of rivaroxaban with a upper bound margin of 1.4, but it was not able to demonstrate non-inferiority. And the last of these trials, which came out recently, was the ASTRO-APS trial. This time around, apixaban was being compared against vitamin K antagonists. And initially, the lower intensity of apixaban, 2.5 milligrams BID in patients with thrombotic APS was selected. And down the line, while the study was ongoing, a determination was made to amend the protocol and use the higher dose of 5 milligrams twice daily. And they were planning to enroll 200 patients, but similar to one of the prior trials that I was alluding to, this one was also prematurely terminated. And in part, this was related to excess in arterial thrombotic events, which happened in 6 patients on assigned to apixaban, but non-assigned to vitamin K antagonists. So there has been this continued uncertainty that I was alluding to, but none of these randomized trials alone was able to sufficiently provide proof one way or the other. And because of this continued controversy, we were fortunate to put together a team of experts to do a comprehensive systematic review and meta-analysis to generate additional insights. And this paper was recently published in Journal of the American College of Cardiology. So in this comparison, the method that we had was initially we prepared a protocol. We registered the protocol in Prostro for transparency, and the study was based off of a systematic search of PubMed, Embase, Cochrane, and others to make sure we are capturing all the relevant randomized trials, including the few that I was alluding to. We even looked at clinicaltrials.gov to see if there are other major ongoing randomized trials that we need to think of. And we set out some certain exclusion criteria, including non-RCTs or those that use the crossover design, because that wouldn't necessarily give us a good sense of causal inference for long-term outcomes. And we also excluded studies wherein patients might have had APS, but not the thrombotic form of ACS. One of the interesting parts of this study that I will get to later is it was a little beyond just pooling the results from published papers. We did pre-specify to look at certain subgroups, and we did pre-specify that if the data were not reported in prior publications from those subgroups, we would reach the PIs of individual trials for unpublished study level output from those studies so that we would be able to pool them and inform the results based off of particular subgroups. And in 3 out of the 4 cases, we were fortunate to receive good response and collaboration from PIs of the trials. The main outcome that we had for this study based off of the data that I shared with you was the composite of arterial thrombotic outcomes. We had a separate main outcome for venous thromboembolic events, and obviously we explored a lot of other outcomes, including composite thrombotic outcomes, individual components of arterial thrombotic events, among others. And we used the Cochrane criteria for risk of bias And we used the great criteria so that we would be able to assess the certainty of the results per outcome across the pooled studies. I already mentioned that we had pre-specified subgroup analyses, including in women versus men, those with versus without triple positive APS, and certain other subgroups. This is the flow diagram of how we screened the study. Suffice it to say that ultimately we were able to find only 4 relevant randomized trials whose results were completed. And this beautiful summary graph by my 2 brilliant postdocs, Dini Kairani and Antoine Bijani, summarizes some of the features of these trials. Essentially, what you see is that most of the trials used a standard anticoagulation intensity for the warfarin arm, even though for some patients a higher treatment strategy with vitamin K antagonist was chosen. And also we alluded to the fact that in Astro-APS trial, some patients received 2.5 milligram twice daily of apixaban, whereas later on, they changed the intensity of apixaban to a higher intensity. And here are the rest of the baseline characteristics of these trials shown in this graphical summary. In essence, the average age is a little bit less than some of patients with thrombotic diseases that we see. And in part, it's because this population is particularly at risk. So the age of onset of disease might be earlier than some other thrombotic conditions that we see. And nearly 2/3 of patients were females. So looking at the outcomes, which is the more important part of the results, we will start off with the composite thrombotic events for arterial disease. And as you can see, we do have the numbers for individual studies. We mentioned that RAPS didn't have events and the rest of studies are summarized. I want to point to the pooled estimates, which shows an increased 5-fold odds in the risk of subsequent arterial events. And this is, as I said, subsequent events. So it doesn't matter whether or not the initial event was VTE or arterial thrombosis. We are following these patients to see what kind of thrombotic events happen in future. And people assigned to DOACs compared to VKAs had an increased odds here. Looking at individual components of it, myocardial infarction had a increased odds, but it did not reach statistical significance. As you can see, the lower and upper bound confidence intervals cross one and the results are non-significant. For stroke, however, here is where the majority of events happen. As you can see, the first trial had no events. Second trials, all stroke events happening in the DOACs arm, similarly in the 2 other trials. Because of this, we noted a clinically relevant increased odds of subsequent stroke, almost 10-fold. Of course, the upper and lower bound confidence intervals are still pretty wide. So we don't know what the exact point estimate should be, but it was something noteworthy. When looking at venous thromboembolic events, however, there is really neither a clinically relevant or statistically significant difference between DOACs and VKAs. And similarly, when we look at forms of venous thromboembolic events, for DVT, there is no difference, and the results are relatively similar for PE as well. Again, the point estimate is more than 1, but the confidence intervals are pretty wide to the extent that you would not be able to make an inference. And truth being told, it's driven only by a single event. Looking at major bleeding events also, there is no statistically significant or clinically relevant difference between people assigned to vitamin K antagonists versus DOACs. CR and MB, clinically relevant non-major bleeds, again, we see some point estimates toward increased odds with DOACs, but confidence intervals are wide. So this is interpreted, especially considering multiplicity of comparisons, as non-significant as well. Here is where we get to the subgroups. So some of what I already presented was in part known before we did this analysis. We just confirmed them. But here, we do some interesting pooled analyses within subgroups. The first one that I will allude to is for people with triple positive APS versus single and double. 2 disclosures here. One of the trials only included triple positive patients, and in another of the trials, they also reported data for historical APS, so less certainty. But with those caveats, when we are looking at subgroups, it's important to look for effect modification or interaction. And we see that the results were directionally similar for triple versus single and double positives. And there was no statistical test of heterogeneity that turned out positive. What really happens with single positive, the numbers were small, so we did not analyze, but to the extent that we could see, no interaction so far. Similarly, we looked at the qualifying event, meaning what the initial thrombotic event was. Is there a difference for people who had arterial thrombosis versus people who did not have a history of arterial thrombosis? And again, we did not see an effect modification, meaning that the results were relatively similar. And women versus men is a subgroup that caught our attention because directionally it looks as if in women the findings are more pronounced. However, with the numbers that we have, it's only safe to conclude that there was no significant difference. Would it show a difference if we had double the number of patients and events? It's a question for future, but nothing for certain for now. So this is results per subgroup for arterial thrombotic events. Now let's pivot into subsequent venous thromboembolic events. It's a lot of numbers, but to make a long story short, there was no difference between those subgroups that I alluded to, similar to the overall results. So between people with triple positive versus single or double positive, women versus men, and people with prior arterial thrombosis or not, there was no significant difference in subsequent risk of VTE, whether they were assigned to VKAs or they were assigned to DOACs. When we looked at major bleeding events, it's also similar, meaning that we did not find any evidence for distinct effect for people with any of these three subgroups, being people who've had history of triple positive versus not, people who've had a history of arterial thrombotic events versus not, and women compared with men. So this is the aggregate results that I was alluding to. And when we looked at the risk of bias for these trials, most of them adhered to a lot of good standards for methodological design and reporting, the exception being that these trials were not double-blind, so they were open label, something to consider. And when we looked at the grade criteria, based off of the criteria that they have, and we already discussed the point estimates for arterial thrombosis and particularly stroke were so significant that ultimately we felt that there is high certainty in terms of grade criteria for the results to be relevant. For the other outcomes, VT and major bleeding, there is moderate certainty. So the question is, if we take these data as a whole, why were the DOACs less effective in the subgroup study than these randomized trials? Is it an adherence issue because it's more concerning for DOACs? Is it because of the short half-life? It's possible, but personally, I'm not convinced, in part because the time in therapeutic range in those trials was not dramatic. It was not like 85% or 90%, but it's still a hypothesis. In contrast, in the apixaban trial that I was alluding to, ASTRO-APS, adherence to apixaban itself was nearly in all patients, 97%. Now, the other thought that some experts have proposed is that maybe thrombotic antiphospholipid syndrome is one of those conditions in which you really need to block the coagulation cascade at multiple points as opposed to single targeted blockage. Is this the cause or not? I think it needs more investigation. Another very interesting point is now there is another randomized trial going on, RISPES, which is randomizing patients to a higher dose of DOACs compared with that studied in prior studies. So here they're using similar to the loading dose for acute VTE. It's 15 milligrams twice daily of rivaroxaban versus vitamin K antagonists. So the bottom line of the study, as you can see, is summarized in this lower left-hand corner. We noted for people based off of 4 trials who were randomized to vitamin K antagonists versus direct oral anticoagulants, there was an excess in risk of subsequent arterial thrombotic events, which is predominantly driven by subsequent stroke. There is also an increase in the composite outcome, but we need to keep in mind that venous thromboembolic events and major bleeding events did not have a significant difference, and neither did all-cause mortality. with that, I would love to acknowledge all my colleagues and mentors who have helped with this project, and particularly commend my two great postdocs, Dini and Antoine, who were really instrumental in doing these analyses, and all of my other mentors, the Anticoagulation Forum, for this opportunity, my colleagues and mentors and collaborators at the Brigham, American Heart Association, Yale, CORE, and others. And I'm very honored to be with you, and I would pass it to Dr. Barnes.
Thanks so much, Behnood. Deb Siegal here. I'd just like to thank you so much for that informative talk, and I'm sure there are already a lot of questions coming in, and I think we'll have a great discussion. I'd like at this point to invite Jean Connors to make some comments in preparation for Surabhi coming up next with the rapid resources. But Jean, we'd be interested in any thoughts you have that you wanted to share at this time on some of the results that that Behnood discussed, thinking of course that we're going to go into some more detail about specific questions later on.
Oh, thanks, Deb. And again, I, like Behnood, want to thank AC Forum for inviting us to discuss these results. I was delighted to be invited by Behnood to participate in this meta-analysis, because this is such an important clinical question that comes up. And as Behnood walked you through the trials with small numbers, it's really hard to make a strong conclusion. So strengthen numbers in this meta-analysis. I want to reiterate the points that Behnood brought up about the qualifying VTE to get into these qualifying thrombosis. Actually, there's the Freudian slip, right? Because no matter whether you had a venous thromboembolic event or an arterial when you were randomized, you ended up, the risk of recurrent events was purely on the arterial side. And if you looked at one of the data slides that Behnood showed earlier, less than 20% of patients enrolled actually had a qualifying arterial event. So I think this really speaks to, as Behnood was getting to with regards to the mechanisms, something unique on the arterial side that VKA does a better job protecting than DOACs. The Astro APS trial, also when they made the dose modification change, they also excluded patients who had primary arterial events as their qualifying antiphospholipid syndrome diagnosis. So again, maybe even in less at-risk population, right? Because we're screening out those patients. So all in all, I think this is very important data. We do have some small numbers, and I know we're going to want to discuss the difference between triple, double, and single positive, but what you see from this trial, again, a question I get asked every day: my patient had a popliteal vein thrombosis and only has one positive test. What do we do? So more for us to discuss when the questions come up. Thank you.
Okay, thanks so much. So it's my pleasure now to bring on Surabhi, pass the mic over to you to share your slides on the Anticoagulation Forum, rapid resource thrombophilia testing, and antiphospholipid syndrome. So take it away.
I would also like to thank AC Forum for the opportunity to present this rapid resource. So we're going to be talking about the rapid resource for thrombophilia testing and antiphospholipid syndrome. This is a 2-page document that's available on Anticoagulation Forum website under the Centers of Excellence. I would also like to thank all of the contributors for this rapid resource, and to name them, they are listed on the bottom of the rapid resource, but to acknowledge them today, it's Gregory Hadlock, Linda Kelly, Arthur Allen, Lindsay Courtney, Bishoy, and our reviewers, Anita and Deborah Siegal. This 2-page document can be found, as I mentioned, on the Anticoagulation Forum website. If you have that in front of you, it would be great to pull it up or print it in front of you such that we can follow along next few slides.
Surabhi, can you advance?
Sorry.
Maybe use the arrow on your keyboard.
There we go. Yes. I apologize, having a little bit of technical difficulty.
I was able to go forward with the mouse. Maybe try clicking with the mouse.
There we go. Thank you so much. So to start out, thrombophilia can increase risk of venous or arterial thrombosis. But it's important to note that presence of thrombophilia is only one of many elements that determine risk of thrombosis. This is why need of thrombophilia testing to inform prevention or treatment decisions is controversial. This slide highlights prevalence and risk of thrombosis for thrombophilia. What I'd like to draw your attention to is the first row, which is factor V Leiden heterozygous. What this shows is that prevalence of this thrombophilia is 2 to 7%. However, the absolute annualized risk of initial VTE is 0.05 to 2.2%. And now if you look on the bottom of this table, APS has a prevalence of 2%. However, relative risk of initial VTE is quite higher at 7, and then relative risk of recurrent VTE is even higher, 1.5 to 6.8. What this slide is showing you is that prevalence of thrombophilia is rare or low, but the risk associated with VTE could be much higher. So it's important to pay attention to which thrombophilia you're looking at. There are common types of thrombophilia, inherited and acquired. So patients with inherited thrombophilia, what we're looking at is genetic mutations affecting amount or function of a protein. So when there's loss of function mutations, we think of antithrombin deficiency, protein C and S deficiency. But when there's gain of function mutation, we think about factor V Leiden, prothrombin gene mutations. Acquired thrombophilia is APS. So what we did in the rapid resource was on the top right-hand corner of the thrombophilia testing the rapid resource, we have highlighted for you mild thrombophilia and strong thrombophilia. Strong and mild thrombophilia refer to relative risk and increased risk of recurrent VTE without anticoagulation. So this is really good table to look at when looking at your patients. So patients with mild thrombophilia will have lower risk of VTE compared to patients with strong thrombophilia. This is why patient selection is very important when thinking about thrombophilia testing. So patients with family history of VTE, we would want to consider thrombophilia testing in. Patients without family history of VTE, we would still want to consider thrombophilia testing, but those patients would be young patients less than 45 years of age, patients with recurrent unprovoked thrombosis despite antithrombotic therapy, or patients that have had thrombosis in multiple venous unusual sites. We've also considered it in patients with history of warfarin-induced skin necrosis, since those patients could have protein C deficiency. Arterial thrombosis and patients with APS is suspected. What we've also done in the rapid resource on the bottom is to compile a table with common thrombophilia tests. We've broken this table down into functional and clot-based testing or non-functional antibody genetic testing. So for example, if you were to order lupus anticoagulant for one of your patients, and this test was prolonged, so what that would mean is that there's possible suggestion of lupus anticoagulant presence. But it's important to note that if this test is done during an acute thrombosis, pregnancy, infection, or malignancy, that this test may be skewed a little bit. Also, it's important to note that if a patient's on anticoagulant, you may not want to have lupus anticoagulant testing done. So in what I have done in the past as a pharmacist on the team with the heme consult service is if we are suspecting APS in a patient and thrombophilia testing would be ordered, I make sure that the heparin drip hasn't been started prior to sending the testing. On the bottom, we have genetic testing mentioned as well. This testing doesn't typically have any effect with anticoagulants, but we still need to keep in mind potential conditions that may influence testing. What I particularly love about the rapid resource is the bottom line. So this is on the top left-hand corner of the thrombophilia testing rapid resource. What we do as a panel that puts together this rapid resource is to really distill information that you want to take away from the rapid resource for your institution. So for example, for thrombophilia testing, we recommend that you have institutional protocols to limit guidance of thrombophilia, to limit and guide thrombophilia testing. Also, we recommend that you have a personal and family history taken for every patient that comes with VTE history for those that you would consider thrombophilia testing in. We also try to do a good job of trying to point out what we recommend not doing. So many times anticoagulation is prescribed for patient with thrombophilia testing is positive, but there's no family history of thrombosis. So we want to really advise you not to do that. Also, when you're doing functional clot-based testing, it's important to not have a patient on anticoagulant, as I mentioned before. And I think the last two columns are really the ones where we practice the most in, which is the gray area of our practice. And this is where we highlight, for example, under the consider column, we highlight that negative thrombophilia test does not specifically indicate low risk of VTE. And then also the caution should be taken when interpreting thrombophilia testing. At our institution, we always have our hematologist review the thrombophilia testing results to help us better guide prevention and treatment of thrombosis, and also making sure that patient doesn't have any acute medical conditions when we're ordering the thrombophilia testing. So some of this was covered in the previous slides, but the second page of the rapid resources diagnosis of APS. So we spent a little bit of time of highlighting the diagnosis because it is quite complicated. But what you really want to think about is that when thinking about APS, the patient must meet clinical and laboratory criteria to be considered or confirmed diagnosis of APS. Every institution has different testing that they have available for laboratory criteria. So you would want to consider your coag lab when ordering these tests. But when you do confirm the diagnosis of APS, it's important to repeat it 2 or more times, at least 12 weeks apart, to say that patient has APS. The diagnostic interpretation is also important, that when a patient is considered triple positive for APS, they're high risk for thrombosis. And in this case, we would say that patient has had positive for all 3 laboratory criteria, repeated 2 or more times, 12 weeks apart. Patients with double and single positive APS have lower risk of thrombosis and have only 1 or 2 laboratory criteria that has come back positive. Again, to highlight that transient APL antiphospholipid antibody positivity is common when patient has acute illness or infection, and that presence of large thrombus may falsely normalize LAC testing, which is the clot-based testing, but doesn't really affect the antibody testing. And falsely positivity of LAC testing, which is the clot-based assay, can occur in patients that are on anticoagulants. So what we've also done in this rapid resource is highlight all of the national guidelines that have been available in recommendation for treatment of APS or prevention of APS. And so the first one I have on here is ASH guidelines, which really simply go into saying that APS patients are not candidates for DOACs. Whereas ISTH guidelines say similar, but also kind of define use of vitamin K in APS patients. And they highlight to say that patients with high risk APS should not be on DOACs, but if DOACs are to be considered, shared decision-making should be utilized, and it should really be in non-high-risk patients such as double positive or single positive APS. The 2 more guidelines that we have highlighted in the rapid resource are ESVS, which is the European Society of Vascular Surgery. They also say that triple positive APS patients with history of arterial thrombosis, DOAC should not be used. And when vitamin K antagonist is used, the goal INR should be 2 to 3. And then International Congress of APL Antibody Task Force also recommend that vitamin K antagonists should be the first-line therapy for APS patients, and then DOACs are not recommended for use for APS patients. Going to the bottom line of the APS rapid resource, we highlight similar columns as we did for the thrombophilia testing, where we recommend that accuracy of APS diagnosis is made at 2 different occasions, 12 weeks apart, and that vitamin K antagonists are recommended for management of thrombotic APS, specifically in patients with triple positive and arterial thrombosis. We also recommend not to do LAC testing while patient is on anticoagulants, as that can potentially skew the results. And also recommend that patients that have APS, it is recommended not to anticoagulate if they do not have history of thrombosis. It's really important for these patients when doing any sort of surgery to do peri-procedural bridging, since patients' vitamin K would be interrupted, and these patients are triple positive or high risk for thrombosis. And in the caution section, we highlight that for triple positive APS patients, vitamin K antagonists should be considered as first line. However, if DOACs were to be utilized, it's important to make shared decision-making with our patient and really be considered in non-high-risk patients such as single positive or double positive patients. With that, we will move on to the Q&A section.
Well, Surabhi, thank you so much. That was a wonderful summary and clearly an incredibly useful rapid resource. I know is going to be something everyone here on this webinar is downloading. I also want to thank everyone for participating. We're getting a ton of great questions. In about the next 20 minutes or so, we'll try and get to as many of those questions as possible. Jean, Surabhi, thanks for coming back. Behnood, I welcome you to join us here. We've had a lot of questions around diagnosis. And so Behnood, I might start with you if you don't mind. You summarized a bunch of that in your slides, but we're getting questions really about some of the practical pieces of diagnosis of antiphospholipid antibody syndrome. For instance, you highlighted that 12-week period. How do you coordinate that? How do you decide when to do testing if somebody's on a vitamin K antagonist? How long do you hold the vitamin K antagonist for? The same thing with DOACs. Any tips or tricks you can offer us about the diagnostic piece and how you coordinate that?
My personal tip is I refer to Jean and she always guides us in the best way possible. I'm not sure if that's feasible for the rest. A lot of times we seek guidance, but generally speaking, if the patient is on a DOAC, it's an easier hold. And most of the antibodies other than lupus anticoagulant, to my limited knowledge, do not interact. So you can safely test them even while people are receiving anticoagulant therapy. Obviously, for lupus anticoagulant, it's trickier. If I'm fortunate to be on the inpatient side, we put on unfractionated heparin and it's going to be a short hold. If it's in the outpatient side, it's more challenging because we also want to weigh the low but real risk of interrupting anticoagulation for several days. But I would love to hear if Surabhi, Deb, Jean, or you have additional thoughts.
Well,
Jean, care to comment?
Yeah. I have a lot of thoughts. And no, one of the first things, as Behnood is aware, is that not every patient with a VTE has to have antiphospholipid syndrome testing. I cannot stress this enough. I mean, patients who've had major surgery, who have major provoking obvious factors, patients who have cancer, there is no need to check for antiphospholipid syndrome, antiphospholipid antibodies in those patients. It's the patients who have an unprovoked event, that's a VTE. It's the patients who have arterial events and they're young. And these patients, you get to recognize, you know, who should be tested for these. You know, the coordination of testing is tough, right? So and I'm sure we all have a cadre of patients with different degrees of antiphospholipid syndrome testing, right? Or syndrome itself. So I have patients who've had multiple thrombotic strokes, who've progressed through standard anticoagulation, and that's their only manifestation. And they have recurrences very quickly. You know, once you've got some positive antibody-based ELISA tests and they're high, you don't need to stop to see whether the DRVVT or the PTTLA is positive and whether they're triple or you know, double or single. Those patients clearly have APS, and it takes a while to be able to recognize who the patients are who really should be subjected to APS testing, because as we've all mentioned, it is difficult to perform the testing, and it's also difficult to interpret the testing. And that's really where, you know, it's worth looking at the titer, right? So, you know, we see people all the time refer to hematology who have an anti-cardiolipin IgG of 23 and the upper limit of normal is 19, right? Yeah, and then you compare that with somebody who has a beta-2 glycoprotein 1 IgG of greater than 5,000. Right. So I think and it's our comfort level with seeing that spectrum that enables us to discriminate. So if you have any questions, you know, you can always, I think, refer to vascular medicine, to cardiology, to hematology, to experts in that field to help make that decision.
I think that's a really important point, like many really important points that Jean, like real pearls that you just raised. I think, one of the ones that stands out for me is patient selection and understanding who is a candidate for its testing and who is not. And we've all run into situations where testing has been done and it's very difficult to interpret the results. But some of the other things I think that are challenging for people is to understand maybe that there are differences. Do you consider different gene types of antiphospholipid antibody tests differently? For example, is there a difference between a cardiolipin or beta-2 glycoprotein 1 antibody and lupus anticoagulant? Or does it, you've already talked about the level or the titer, but like, does the type matter? So does IgG make a difference compared to IgM or sometimes IgA, which we don't actually measure at our center? But I know that often comes up. Are all of those treated equally?
No, and that's a great point, Deb, because the IgGs are felt to have much higher specificity for being associated with thrombosis, right? And one thing, to point out is that when you look at studies of healthy blood donors walking around, 1 to 5%, and some would even say 9% can have a positive antiphospholipid antibody, but they're usually transient. And even in those that are persistent, if they don't have a clot, then there's nothing to do. So we do put more reliance on the IgG subtypes. There's a reason, Deb, that IgA isn't tested in most academic institutions. There was a recent revisitation of the role of antiphosphatidylserine by the ISTH Committee on Antiphospholipid Syndrome, and found that it did not add to being able to make a diagnosis of APS. So when we look at the Sapporo criteria or the subsequent revised Sapporo, the Sydney criteria, it is with a anticardiolipin, beta-2 glycoprotein 1, and the clot-based assays alone. And that other ones that you may come across do not carry much weight with making the diagnosis. They're not part of diagnostic criteria for valid reasons. So again, I think, the other thing, I see this all the time, and I tell my patients, kids who have strep throat will have a positive anticardiolipin antibody, right? So you have to look at what's going on with the patient. This was also a thing with COVID. Many people tested one time antiphospholipid antibodies, and, were these responsible for thrombotic events, or were they really just what we see, as a bystander activation of inflammation and what we would expect in sort of any sort of infectious situation. So you need to getting back to Deb's point, selecting the right patient, right? Someone comes in with pneumonia and is intubated and has a DVT in the ICU. There's no point in measuring antiphospholipid antibodies in that patient.
I'd like to build off of that. And Surabhi, maybe I could ask you, you commented in your presentation about being on the thrombosis service, and you're often working with clinicians and helping them decide not just testing, but also management. The meta-analysis that Behnood showed had this really striking feature where it was the arterial thrombotic events, particularly stroke afterwards, that was really different between DOACs and VKAs. Because of that, should we be testing all patients with acute stroke for antiphospholipid syndrome? Are there other things that in the hospital setting we should say, hey, these are the patients in whom we should be thinking about testing? And systematically, how do you think about operationalizing some of those roles? Do you have any thoughts on that?
Yeah, I think just to kind of start out, there are not many pharmacists that are usually on a consult service for hematology. So by the time hematology is consulted, patient has already been started on an anticoagulant. So I think that makes it very challenging to really order APS testing. So to your point, if someone is coming in with a stroke, we are going to start anticoagulation therapy as soon as possible if the diagnosis is of arterial thrombosis. So I think in those situations, kind of like Jean mentioned and Deb mentioned, we try to not order APS testing at that time because it's going to skew the results. And, in form of management, I think we could wait till the patient is seen in a clinic after 12 weeks or so, or once they're discharged, where anticoagulation can be safely discontinued before we send APS testing. Now, having said that, there are many times APS testing is still ordered, before heme has been consulted. Our hematologists and many hematologists at academic settings can interpret APS testing results while patient is on anticoagulants, specifically vitamin K antagonists, or even heparin. Again, we would have to repeat that testing 12 weeks later to confirm the diagnosis of APS, and it's not going to change management. So really what that's telling us is we're getting another data point, but it's not changing management. So in my opinion, I try to, if we're asked, should we order it? I try to defer it, but if it's already been ordered, we try to interpret and wait for the confirmatory result before making diagnosis of APS.
Can I make a quick comment, Geoff, as well? It's kind of a disclosure than comment. So after finding the results that we did, as Jean was elegantly mentioning, for people with unprovoked VTE, it's a very, or young people, other unusual situations, it's scenarios where we feel comfortable testing, and we completely agree not to test routinely. What made me uncomfortable, and I don't have an answer, just a question, is are there other subgroups for which we should be doing testing? I don't have an answer. I don't think we have enough of epidemiological studies to recommend it widely, but I think that would be an interesting question for future research.
Yeah, no, there are, I'm going to segue right and jump right in. There are a lot of questions. I think this, data is the best to help guide clinical care as it stands today. But, I can sit here and discuss potential role of aspirin on top of anticoagulant therapy in patients with APS. I can discuss, again, sort of, selecting the patient, right? Your 79-year-old vasculopath, which, Geoff and Behnood, those guys very well. And, carotid stenosis is the thing. And if they've got an MCA stroke or AFib, it's pretty straightforward. It's more the younger patients who don't seem to have a provoking factor that we really worry about APS as the cause of a thrombotic stroke. And so again, I think, but as Behnood said, there may be subgroups of patients in whom we need to pay closer attention.
I think I'm just going to jump in briefly off of that, Jean and Behnood. Really good point. So things that I think about in my clinic, which help me steer me towards one or the other, test or not, are things like, a high, an underlying autoimmune or rheumatologic condition. These are things that we would all think about, but it's helpful to conceptualize. Unexplained thrombocytopenia, because one of the manifestations of APS is, of course, ITP or immune thrombocytopenia. So those are this, or if somebody has, signs or symptoms of lupus, which I've had in my clinic, those are, I would have a much lower threshold for testing kind of earlier on, and it can help, again, try to just identify who those patients are. But, some of those situations, infections, inflammation, malignancy, people who are sick with acute illness in hospital are all scenarios where you have, the possibility of finding an antiphospholipid antibody that's transient. So you just have to keep that in mind when you're doing these tests. And that's why, of course, we repeat the testing at 12 weeks to confirm that it's persistently positive. Yeah, I wanted to actually maybe get some thoughts. Maybe I'll direct this one to Behnood, just to get maybe some of your thoughts around. There's a lot of questions about treatment too, and we want to be able to talk a little bit about some of your treatment findings. There's so much to talk about with this. And so lots of folks wondering whether or not it's ever appropriate to use DOACs for APS. I know that you've summarized the data. Certainly we've all had situations where we have done that, perhaps reluctantly for various reasons, but are there patients in whom you would feel comfortable using a DOAC, or is it always a vitamin K antagonist?
Thank you so much, Deb, and that's a great question. The answer to are there patients I've used them in is yes, and you appropriately mentioned the data are always helpful for us to understand things and to have a clear shared decision making with our patients. And it's really beyond what we see in a yes, no dichotomy, this is the right treatment, this is not, and gets to the point that you and Jean were talking about the titer of antibodies, the type of antibodies, the patient's social situation. Are they able to check their INRs frequently? And some of the patients, as both of you know better than I do, they have challenges with INR monitoring because of the disease itself. Some centers do not have assays that can overcome that. So all of those being considered is important. If there is Triple positivity, I would be more concerned personally. If there would be arterial events, I would be more concerned, not the qualifying event, meaning history of arterial thrombosis while the patient was on treatment, and now it's like a subsequent treatment episode. But generally speaking, I would share the risk and I would let them decide and help me in making the best choice for them.
Surabhi, we've had a number of questions about management of APS with vitamin K antagonists, and specifically people are asking, how do you use that chromogenic factor 10? And is it always necessary, or do you only use it sometimes? And maybe on a similar vein, is it okay to use home INR meters for these folks, or do we have to avoid that? Can you give us some pearls on VA management in this population?
Yes, certainly. This is definitely a question that comes up many, many times. So what we tend to do is when a patient has been already inpatient, been identified as APS positive during the inpatient setting, and they come to see the hematologist in the ambulatory setting for a follow-up for repeat testing. At that point, what we'll do is a test through our venipuncture INR. We also get a INR via our home testing machine that we have available in our clinic, and also do a chromogenic 10 assay. So these three data points help us understand, based on the chromogenic 10, would patient be a better candidate for venipuncture INRs, or would a home testing INR be okay? And I think that those three data points help us guide which way are we going to further manage this patient's warfarin. So for example, if the chromogenic 10 says that patient can be get home testing or venipuncture, then we try to do home testing because that's more convenient for our patients. But if the home testing does not correlate with the chromogenic 10, then we stick with venipuncture. And I think that's inconvenient for our patients, but it is the best management for their APS and also for thrombotic management of their APS. Now, not every institution has chromogenic 10A available, 10 assay available. So for in those patients, we try to really look at the triple positive results of APS to see if the patient was really, all three tests were positive, and we're really worried about recurrence, and we have done the repeat testing and they're still triple positive. We really go over that with the patients to say, we understand the home testing is more convenient, but maybe, venipuncture would be the best way to go for at least a year before we can think about home testing again. And many patients are so worried and scared. And I think those young patients that have just unprovoked VTE are very concerned and are willing to do that.
Yeah, I'll
Thanks,
just
sir.
comment on the type of assay, right? Because we're talking about a factor 10 activity where factor 10 is activated to cleave a chromogenic substrate, not the anti-10A activity, which we use to monitor heparin and low molecular weight heparin. Because I'm sure we see this all the time, right? Someone wants a factor 5 Leiden mutation and they get a factor 5 activity level. So very important to make sure it's a chromogenic 10A. You're going for 10A activity through using chromogenic rather than a clot-based assay. Just had to throw that in.
Thank you for that. That does come up a lot, and I should have clarified. So thank you.
Maybe just to touch a little bit on some of the mechanistic aspects. One of the interesting things that Behnood has mentioned, and Jean, we've all kind of been discussing, is this sort of propensity for arterial thrombotic events. And maybe Behnood, you can start if you want to have some thoughts on this. One of the questions that has come up is that there is an increased risk of arterial events, but these are primarily stroke, and wondering whether we see myocardial infarction with these and why these are limited to stroke. Is there something about antiphospholipid syndrome that has patients with antiphospholipid syndrome that have a propensity for cerebrovascular beds as opposed to other?
That's a great question. So my succinct answer is maybe, and I'll get to it in a minute. As somebody who loves to be data-driven, I think the small number of patients and small number of events limits our confidence in what we can really conclude from all of this. So we are splitting hair. All that being said, numerically, if you looked at the data that I showed, there was also a not statistically significant increase in AMIs. And we've seen plenty of patients who've had recurrent STEMIs only after that being diagnosed with thrombotic APS. So is it possible that they do something distinct for cerebrovascular bed? I think it's possible, but I wouldn't be surprised if it's distinct to arterial bed rather than just cerebrovascular beds. I think more studies always help. And there was another partially relevant question in the chat, if I may address quickly, why the ongoing randomized trial with higher dose rivaroxaban is using the higher dose compared with higher INR target. It's because the patients enrolled, if my memory serves right, did have a history of arterial thrombotic events on standard therapy.
Great. And I think we have time for one more really quick question. And Jean, I'm going to throw this one to you as a very practical question. You have a young patient who comes into the hospital with a venous thromboembolic event, maybe it's a PE. You don't have other clear precipitating factors for this. And so in addition to starting on anticoagulation, somebody chooses to do thrombophilia testing, and sure enough, they show up positive in that acute setting for a beta 2 or maybe it's the cardiolipin. Just based on that initial presentation, do you automatically switch them to a VKA, or is it okay to keep them on a DOAC until you get that 12-week follow-up? Just like practically, what should we be doing?
Yeah, no, that Geoff is an excellent question that comes up at least once a week in practice, right? Because often these patients, are sent out of the ED on a DOAC and none of the test results are back, or at our hospital, they run them twice a week, right? So, I've actually experienced getting people who show up in my clinic who are strongly triple positive on a DOAC, right? So there's not an urgency like, oh my God, you're going to call them in the middle of the night when you're going through EPIC and seeing the results to move them over to VKA, but you do have to sort of make that a plan. And one of the areas that Behnood is going to investigate is the difference between those that have calf vein or, lower extremity DVTs and are single positive versus those that are triple positive and have like a life-threatening PE, right? I think that, is a little bit different situation. If again, we've said this throughout the conversation, if the ELISA-based assays are positive, you can repeat those at 12 weeks, and those are valid whether or not the patient is on anticoagulation or not. If it's a clot-based assay, people have tried a lot of manipulations to try, like hepzyming if the patient's on heparin, but, to see if the clot-based assay is truly positive. Again, in the acute setting, they may have the presence of antibodies that may be transient. You can sort of do that in the outpatient setting as well, 12 weeks later. Someone tried a DOAC neutralization strategy for then running clot-based assays. That didn't work. And that was just recent data. So I think you have to be very careful, but and again, it speaks to the titer. Again, right, someone who comes to me or I'm seeing, 1 week after a significant PE, and their titer is 50, 60, 70, even for an IgG, and maybe both beta 2 and glycoprotein 1 are positive. That's a very different level of concern than someone who has it up in the hundreds or thousands. So again, there's a lot of, this is the art of medicine, right? There's a lot of interpretation of these data. And as Behnood said, we don't have a lot of data to drive a lot of these questions that are asked every day in clinic. And so I'm looking to Behnood to give us more.
Thank you, Dr. Connors, and thank you to everyone for joining us, and to all of our speakers, Dr. Bikdeli, Connors, Palkimas, and our AC Forum board members and moderators, Dr. Barnes and Siegal. As always, this webinar is recorded and will be posted on the AC Forum website shortly. A few quick announcements before we close. If you're interested in additional opportunities to engage with faculty experts, we invite you to join us for a weekend in San Francisco at our upcoming national conference. We have over 85 abstract poster presentations and 16.5 hours of live CE. This is an in-person event not to be missed. Our next webinar will take place on Tuesday, February 28th, and focuses on the impact and outcomes of underprescribing of DOACs for patients with atrial fibrillation. This webinar is accredited for 1.0 hours of EPIC CE, so you don't want to miss it. We talked about a number of resources today. The rapid resource we discussed, as well as a ton of other resources, order sets, and publications are available in the AC Forum Resource Center, along with a monthly literature update that highlights the latest publications on anticoagulation-related topics. You can find the Resource Center at acforum-excellence.org. Lastly, I'd like to thank our corporate sponsors who helped to support this webinar program. Thank you again for everyone for sharing this hour with us, and enjoy the rest of your day.